we have, I think, 5 speakers. I request the speakers to join me on stage, please. Colonel Avinash, Colonel Sandeep, Lieutenant Colonel Vijay, sorry, and proxy for Sanjay Mishra. So I'll be giving a brief introduction on the topic before the other speakers take it on. The majority content is actually from their side. Now, why a session on recruitment in the armed forces? Now, the issue is the type of entry that we have. Now, the peculiarities are that it is tri-service. So we have inputs for the Army, Navy, and the Air Force. We have inputs for varied entries of officers and the other ranks, what we call as JCOs or ORs. And amongst them also now, officers have had women entry for a long time. Now women entry is also starting in the JCO OR ranks also. So there are various parameters. It is different from what we have as routine ophthalmology. There are certain parameters that we need to consider. Now, the unique requirements are that we have different trades in the armed forces. You can have various trades which might be supportive, which might be combat. So you have somebody serving in the combat arms, and it is different in the different services. So if you have somebody in the Army, his trades are totally different from what you have in the Navy or the Air Force. There the trades are different, so their visual requirements are different. Their standards are different depending on their job profile. So it is a totally different cup of tea. Even today, if somebody would ask me offhand what the standards are for the Navy and the Air Force, me being an Army officer, it would take me a while to go into that grid and think, unka standard ye hai. Whereas a naval officer sitting there would straight away say, ye, and I say, okay, she's bang on. So the trades, the unique requirements of the services are there, and you have different trades which differ in the various services. And even amongst that, they are different for officers and the other ranks. So you can see the amount of confusion and the amount of standards that exist because of the various requirement of the armed forces and the services. Now, the unique features that contribute to this are our exposure to various terrains, which is varied, which can vary from high altitudes above 15,000, 9,000 to 15,000, deserts, terrains of the northeast, and a different exposure for the Air Force people and the Navy, which live in a completely different environment. It can be underwater in the submarine or on the ship where they are on the sea for months altogether. So the visual requirements are different, their standards are different. The exposure to different kinds of climate also places stresses on the eye, which are different. So these have been composed keeping that also in mind. And overall, in all 3 services, then there is always the risk of trauma. So there are certain parameters, standards which we follow, which pre-assess the risk of trauma or maybe susceptibility to trauma in these individuals, so that they are safer once they are in the forces. Now, the various parameters that our various speakers will be covering across the session basically is the vision standards. These are different. Refractive surgery, how safe it is in the armed forces, where it is accepted, where it is not accepted, given its advantages, its disadvantages, and the obvious advantage of enhanced vision. But can it still be accepted by everyone across the board? Color vision is again one parameter where there is a lot of variation. It varies across the services. And then obviously the other diseases, which more or less is common across the 3 services and the standards, so that we try and get in healthy individuals who are free from disease and any pre-existing condition which maybe makes them more susceptible to injury or maybe worsening of the condition on exposure to the climatic conditions of the armed forces. So this is the basic structure of the program that we'll give in. We'll be covering the visual standards of the Army, Navy, and the Air Force, the color vision requirement of the various forces, and the place of refractive surgery, and then the 3 standards. Thank you. Now I ask Professor Vijay Sharma to come ahead and give his talk. Thank you. Laptop.
So good morning, everyone. I'll be discussing about visual standards for the armed forces as such. There are various rulings which are available. First, for the officer's entry into the armed forces in the army, this is a letter of 16 July 2019. Now, if we see the various institutes or which take the individuals, young individuals from different sphere. So starting with the admissions to NDA in Army 10 plus 2 equivalent. So in this, the unaided visual acuity which is acceptable is 636 in both eyes with the corrected visual acuity of 6.6. Myopia of minus 2.50, hyperopia of plus 2.50, and a cylinder of plus minus 2 diopter cylinder. So the combined error should not be more than 2.5. So this is what are the standards for entry to NDA Army. The LASIK and equivalent are not permitted at this age for entry to NDA. Now, the next is for the officers who are entering in the IMA, OTA, and women entry scheme and combined defense services. Here the standards are unaided visual acuity by Snellen chart of 6/60 in both eyes, the corrected visual acuity of 6/6 in both eyes, myopia of minus 3.5 diopter sphere, hyperopia of plus 3.5 diopter sphere, and a cylinder of plus minus 2 diopter cylinder. The LASIK and equivalent are permitted in this. In NDA it was not permitted, but if you see the IMA, the LASIK and equivalent are permitted. The next is officers in the Judge Adjutant Journal, so education, RVC, AMC, ADC. In these, the unaided visual acuity, which is acceptable, is 3/60 both eyes. Corrected visual acuity is 6/6 both eyes. Myopia of up to minus 5.50 diopter sphere is acceptable. Hyperopia of 3.50 diopter and astigmatism of plus minus 2 diopter cylinder is acceptable. The LASIK and equivalent are permitted in these. Now, next is admission to Armed Forces Medical College. Now, here the visual acuity unaided is 6/36 both eyes, with correctable to 6/6 both eyes. Myopia of minus 3.50 diopter sphere, hyperopia of plus 3.50 sphere, and astigmatism of plus minus 2 diopter cylinder. These are the visual standards for admission to AFMC, and LASIK is not permitted here. Admission to RIMC, Scenic schools or military schools. Now there are two standards in this, standard 1 and standard 2. In the standard 1, the child has to be 6/6 both eyes. In standard 2, by Snellen, it has to be 6/18 both eyes, correctable to 6/6. The myopia and hyperopia of plus and minus 1.5 diopter cylinder are acceptable, diopter sphere are acceptable, and the astigmatism of plus minus 0.5 diopter cylinder are acceptable. The LASIK and equivalent are not permitted. The Army Aviation. In the Army Aviation, there are two types of entries which happen. One is the direct entry, other is the lateral entry. In the direct entry, the unaided visual acuity of 6/6 and 6/9, correctable to 6/6 both eyes. The myopia of 0.5 diopter sphere, hyperopia of plus 1.5 diopter sphere, and astigmatism of plus minus 0.5 diopter cylinder is acceptable. LASIK and equivalent is not permitted. Whereas in the lateral entry, the 6/12 is unaided visual acuity acceptable to correctable to 6/6 both eyes. Myopia minus 1 diopter sphere, hyperopia of plus minus 2 diopter sphere, and astigmatism of plus minus 1 diopter cylinder is acceptable. And here the LASIK and equivalent are permitted. Now, if an individual has undergone LASIK and equivalent, what should be the criteria that we should see in those patients? The age at the time of surgery should be more than 20 years. There should be a minimum 12 months post-surgery. The central corneal thickness has to be better than 450 micron. The axial length by IOL master should be less than or equal to 26 millimeters. And residual refraction should be plus minus 1 diopter sphere, including cylinder. So, and the retina should be normal and healthy. So these are the criteria which one should look for. Admission to NDA in Air Force. The criteria are 6/6 and 6/9, correctable to 6/6, no myopia. Manifest hypermetropia should be less than 2 diopters, and astigmatism should be less than 0.75 diopter. Similarly, if you see at the initial entry for the fighter pilots, ATC, air crew other than fighter pilots, and flight controller, these are the criteria. In all these cases, if you see the visual acuity, if you see in the fighter pilots, is 6669 is unaided, correctable to 6666. In the air traffic controller, 6969 correctable to 66. In the air crew other than fighter pilots, it's 624 and 636 correctable to 66 and 69. And in the fighter controller, 636, 636 correctable to 6666 with the respective myopia, hyperopia, and astigmatism that you can see in this slide. I think most of these other cases will be covered in the Air Force and Naval standards. So I'll just skip this to mainly now Navy has got its own standards starting from V1, V2, V3. I think these will be covered subsequently. Okay. So I'll just show one more slide of Agniveers. So in the army, if you see the soldiers, these are the normal soldiers, and then there are Agniveers. So in normal soldiers, when we are taking, there are only two visual standards of recruitment of other ranks and soldiers. The soldier GD, gunner and driver and equivalent will continue to require unaided vision of 6.6. And the other category of recruits, they have been grouped in the second group, and they will require the NDA vision standards. So this is the first group where the unaided visual acuity has to be 6.6 in both eyes, and this is the other group where the soldier technical, clerk, SKT, nursing assistants, these will require unaided visual acuity of 636 correctable to 6.6 with myopia of 2.50 and astigmatism of plus minus 2 diopter cylinder will be required, and LASIK is not permitted in these. And in Agniveers, we have got two types of standards. I think this we had some issues in the initial time. Agniveer GD and Agniveer Clerk and SKT. So in the Agniveer GD, 6.6 vision, unaided and corrected. And in the Agniveer Clerk, SKT, Nursing Assistant, the 636 both eyes correctable to 6.6 with the same as NDA standards, and the LASIK is not permitted in them. The rest of the standards will be covered in subsequent talks. Thank you.
Thank you, Colonel Vijay. He's covered the basically the army part and a bit of the refractive surgery. So you can see there are various number of standards which are applicable. The basic thing which comes across is we have standards are titrated according to the age of entry. So it compensates for the refractive errors which change with age. So you have somebody entering at 17, 18. You have somebody entering the Sainik school at the age of 11, 12. So the standards are correspondingly lower, so they correspond to the changes in the refraction which take place at the age of 18, 20, and similarly for the refractive surgery. Now we'll be coming to the refractive surgery part. I request Professor Colonel Sandeep Gupta to kindly speak on refractive surgery, its place in the armed forces and the requirement.
Thank you so much. The important thing is, again, why have standards? So there is a reason why we have standards for armed forces. The reason is we are deployed, the armed forces are deployed over a wide topography, and the engagements are contact based. So the chances of trauma in armed forces is very high. So these are the people who are located all over the countryside at places which are inaccessible. And because of risk of trauma, that is why we need to have a different standards for fitness and visual standards, obviously, for these people. Now, most of these guys in a job with the acuity required is very good. So again, one place, having standards is important. Moreover, if you see the locations which they are in, see in high altitude, in jungles, if you see the casualty evacuation is also very difficult, it takes time. And the medical infrastructure is definitely poor in these situations. So these are the one reasons why these guys, they need uncorrected visual acuity of a very high standard. That is why all these standards are there. Now, things to note is most of this manpower is a young, skilled manpower. The government has invested a lot of money in training these people. Another thing which is there is they have a lifelong contractual engagement with the government. And armed forces is probably at this moment the only place where you get pension. So if you see that angle from the government side, that is why the government of India and armed forces have this standards in place. And there is definitely the monetary compensation aspect which comes later when any of these guys, they get injured or they have problems, and then definitely there are legal issues because of this monetary compensation and contract engagement. That is reason why we have standards. Now, if you see, once you understand this concept of why standards are there, now you'll understand why refractive surgery is not permitted at all at few instances. Like RK is not permitted because obviously the risk of trauma, the risk of corneal rupture is definitely high. Phakic IULs not permitted. Again, the risk of complications in a young patient is definitely high in such a subgroup of patients. Ortho K, why I put it in red is one thing which is there. A lot of people are doing Ortho K, but definitely Ortho K is not permitted because this is just one way. It's a temporary measure to bypass the standards which have been placed. So this is first thing which has to be noted for people who are doing medical examinations or treatment for these guys. A lot of people in civil will be getting somebody who will be telling them that I'm going into army, please give me something so that I can pass that visual standard or the examination which is there. So I'll just explain what all is there. So as already explained, at the level of NDA class 10 plus 12 and equivalent, this is at class 12 level where the kids are at the age of around 16, 17, 18. At this moment, no refractive surgery is permitted. The reason is this is the time when the eyes are still growing, the number may change and the complications may have, there is regression. So not permitted at 12th level. The next level is at the postgraduate level. Now at this level, the age is around 20, 21. So refractive surgeries, apart from the ones I told earlier, the RKs and the phakic IULs are permitted, but with few caveats, which I'll explain later on. Again, the concept behind having refractive surgery at this age is, most of the times, most of these patients, the eyes are already grown, the number is not progressing, and we assume usually a refractive surgery will be done only when the number is stabilized. So that is how the ethical aspect is there, that usually a refractive surgery is done when the number is stable. So that is what the assumption is. At this level, the number is stabilized, and only then the refractive surgery has been done. Now again, these are all postgraduate level, the officers, JAG, education, RBC, AMC. Now these are the people who are less prone to the extremes of postings, as I explained earlier. Also the chances of trauma, contact engagements are less in these scenarios. So these are the people who are in the education branch, the legal branch, the veterinary corps, army medical corps, the dental corps, and territorial RV. Here again, LASIK and equivalent are permitted with few caveats. AFMC, again, the age group is 16, 17, 18, not permitted as explained earlier. Again, we expect the number to change. Now, admission to RIMC, Sainik School, military school, these are the kids who are at the age of 12 years, 13 years. Again, definitely, ethically also, we should not do a refractive surgery. And in this scenario, again, not permitted if it has been done. Aviation. Direct entries, again, these are people who are going through NDA. So again, the age is less than 20, not permitted. Lateral entry after 20 with some caveats, I'll explain later, it is permitted. Now, minimum age as per visual standards of armed forces is 20 years. So any LASIK done before 20 years, not permitted at all. So people who are coming to you for refractive surgeries, please note down the date they have come to you, keep their records, because when they come to us for medical, we definitely check what was the time, what was the age at the time when the LASIK was done. Now again, another criteria which is there is minimal 12 months post-surgery. The reason is this gives time for the regression to stabilize, the number to stabilize, any complication which is there is evident. So again, anybody who comes to you that I have a medical after 3 months, please do my refractive surgery, please don't do. Because again, the date of surgery is checked, and if it is less than 12 months, the person is rejected in this criteria. CCT, understandable, residual thickness of 450, it is basically to take care of. And again, topography is done, so any ectasia has to be ruled out. And again, risk of ectasia in future also is taken care of. As I said, these guys have contractual engagement throughout their life. So again, any person who gets into army has a contract of around 20 years, 30 years, sometimes 40 years also. So that aspect has to be taken care of. So corneal residual thickness more than 450 micron. So when you are doing a refractive surgery, again see what is going to be the CCT post-operatively. If it is going to be less than 450, that person will not be made fit. Now, again, axial length less than 26 millimeter. This is again important. Again, it takes care of any corneal retinal degeneration later on. Now, what we want is a stable residual refraction of plus minus 1 diopter, including cylinder. So this is again important. So this is what we do, and definitely a normal healthy retina. So any person who's coming to you with lattice, which you laser and do a refractive surgery, please tell that guy he will not be made fit in armed forces, because anything in the retina will be a sure shot unfit or rejection. Now for soldiers, again, when they enter army, the age is 17 years. Again, as explained earlier, refractive surgery in any form is not permitted. And even if they join later on, again, they are at far-flung posts. We need younger manpower. They are more prone to trauma, and definitely the visual acuity required for them is definitely more. They are at the forefront of our war. So age criteria is one. Second thing is because of these criteria, soldiers at the level of soldiers, refractive surgery is definitely not permitted at all. Now, in Navy and Air Force, few conditions are there, and with that, again, one is pre-op refractive error has to be less than 6 diopter. Again, this is a criteria being given by us. Again, that is the reason why the pre-op records are checked. So anytime you are doing a refractive surgery for somebody who's going for armed forces, their pre-op records have to be seen. So this is one criteria. Age after 20 years or 12 years, uncomplicated surgery, stable post-op refraction, the same criteria is there. And optical biometry is done. This axial length of 26 millimeter is taken because it is a objective criteria which doesn't differ from person to person. And again, please, there are few more things. In Air Force, LASIK or refractive surgery is permitted only for ground duty branches and short service commission, only in transport and helicopter stream only. And in Navy, the people who have done refractive surgery unfit for submarine, people who are on submarines and Marcos, again, the chance of risk of trauma or extreme weather conditions, extreme pressure conditions are there. That is the reason why these guys have been kept out of purview of refractive surgery. And in air crew for Navy, only difference is that axial length required is less than 25 millimeter. This is again not taking chance with the retina or any extreme G conditions. That is where you can have retinal weak retinas may tear up. So that is the reason why the axial length is kept at 25 millimeter. So reason is, in Air Force and Navy, the standards are more rigid than Army. Reason is that it's highly specialized job profile. Any aberrations will interfere or risk their expensive equipment as well as the lives of the trained crew. And as I already explained, the physiological conditions are already extreme. That is the reason why it is kept. So what I advise to general ophthalmologists, that what I want to tell them that armed forces have trained manpower. And we are looking at every person who are coming to us with a high index of suspicion. Every person undergoes refraction. Topography is easily available everywhere. So any person who tries to bypass the system by undergoing any refractive surgery is caught very, very easily, because equipment and everything is there. And best part is we are looking at them with high index of suspicion. So again, orthokeratology is going on like anything. Again, it's a temporary thing, but we can catch it very easily, and because topography is available everywhere. So that is the advice. Please don't do ortho-K for people who are going for armed forces recruitment, because unnecessarily that person will be rejected. Then second thing is, don't do any refractive procedure before 20 years of age. Keep records of pre-op refraction as well as date of surgery, because this is again a very important criteria. Do PACKI fundus examination, axial length, and for all, and keep a meticulous record for all these guys who are coming for armed forces recruitment. And in the end, this is very important. What I want to say is, armed forces is a vital part of society, and our needs are different than most others. So all of us have got a social and ethical responsibility to not try and do things which harm these people and the organization later on. standards are easily available with advertisements. So anybody who's coming to you and asking for a refractive surgery for anything, please check the standards which are there for that recruitment. It is available with the advertisements. And finally, I want to just convey the fact that most procedures are detected and it leads to rejection in these guys. So please, whenever anybody comes to you for refractive surgery for armed forces, please go through these points. Things are better for that person also and the organization also. Thank you so much.
Thank you, Sandeep, sir, for very elaborate talk about the various LASIK and its other refractive surgery requirements in the armed forces. Next, I would like to invite Colonel Avinash Mishra, sir, for his talk about visual standards in Air Force and Navy. Meanwhile, till the time sir set up his laptop, you can ask any question till now about the visual standards in the LASIK, if anyone has any questions. Yes.
If candidate undergo PRK surgeries, how you identify this? Whether you do topography for every candidate?
There are two points in this. One, if an individual has reported to any center, then all his keratometry values are recorded there. So after he gets unfit and then he undergoes a PRK, when he goes to the next center, again his keratometry values are recorded. So you can find there is a significant change in the keratometry values. You can catch hold of them. Second is, it's very difficult if an isolated, very low refractive error PRK has been done, it's very difficult to catch them. But then other criteria such as the corneal thickness, they should be met. So,
one more thing is there. Usually most of these guys, they come within 10 days, 15 days, 20 days, or within a month of the surgery. So that is the time. That is the time period they get for appeal when they get rejected for the, say, visual acuity. And the time period is around a month. So if you do any refractive surgery, it is usually caught in that time. So it is never that you get a patient and you do. Obviously, if a PRK has been done around 6 months or a year back, then obviously we won't be able to catch. But most of the times, the time period is a month only, so that period it is easier to catch.
Fair enough.
Hello. Avinash Mishra, sir, we will be presenting about visual standards in the Air Force and Navy. Over to sir.
Hello, a very good morning to everybody. Greetings from Jalandhar. At the very outset, like Vijay mentioned, that I will be covering Air Force and Navy, but frankly, most of it has already been covered by him. And whatever was left has been covered by Sandeep. So I'll be gently just repeating what they have said. Of course, the pictures are new. You can enjoy the pictures. Okay, now starting with the Navy first. Visual acuity. Like in any other field of TIL, visual acuity by far is the most important criteria. Normally for this, we use the Snell's chart at a distance of 6 meters. And like we all are aware, the illumination should be minimum 10-foot candles. Obviously, each eye will be tested separately. Near vision is usually not tested in our examination. Color perception. The Ishara chart is used for screening. It should be done. The most important thing about using an Ishara chart is that it should be done in very good light, preferably outside in daylight. If that is not possible, which is usually the case, then it should be done under good illumination, preferably via tube light. If Ishara charts are not available, then we can use the Tokyo Medical College book. Martin lantern. Martin lantern test is basically the gold standard for differentiating between CP1 and CP2. Now, it basically consists of a box which has got apertures of different sizes, 0.3 mm and 1 mm. And then at a distance of 6 meters in a totally dark room, the candidate is supposed to identify the primary colors at a distance of 6 meters. If he can identify all the colors correctly at a distance of 6 meters, then with the aperture size being 0.3, then he is considered as CP1, otherwise CP2. Hypermetropia should be done under full cycloplegic refraction. Fundus examination should be done under full mydriasis. Now the standards, as far as the officers are concerned in the Navy. The pilots obviously require the best possible vision, so they should be minimum 6x6 in the better eye and 6x9 in the worse eye. and it should be correctable to 6 by 6. CP1 is the basic requirement. As far as the executive cadre is concerned, they are allowed a little bit of refractive error, but it should be correctable to 6 by 6 in both eyes. Again, the requirement is of CP1. The technical group, the refractive error allowed is more, and they are allowed to be CP2. As far as the education group is concerned and the logistic group is concerned, they are given the maximum leverage. Vision up to 6 by 60 uncorrected, improving to 6 by 6 is a basic requirement, and they are allowed to be CP2. Near vision, usually again not tested. In case a patient has, a candidate has a near vision issue, then best possible correction is given to him. As far as the muscle balance is concerned, well, for the limit for heterophoria for distance, it should be measured at 6 meters and tested by the Maddox rod. For heterophoria for near, again tested by the Maddox rod at a distance of 30 centimeters. Ocular movements obviously should be full and free. The visual acuity is tested by the confrontation method. Now, like I mentioned earlier, for color vision, we use the MLT. Laser therapy for correction for myopia, refractive errors, is not allowed. Night vision is usually not tested, and it is only tested when there is a suspicion of congenital night blindness. Other causes of rejection can be any crossing inflammation of the eyelids or the adnexa, trachoma, xerothalia, and pterygium. Of course, media opacities involving the cornea and the lens are a cause for rejection, especially if it involves the visual axis. Manifest squint is an absolute rejection. Ptosis, severe ptosis. Now, coming to the sailors and agniveers. First, the entry for SSR. For SSR entry, they allowed 6 by 12 vision, improving to 6 by 6. Color vision, CP2 is allowed. For the MR entry, the refractive error allowed is more, and they are allowed to be CP2 too. Wearing of glasses is generally not permitted for direct entry cases. However, once they are allotted their particular branch, then they are allowed to wear glasses up to the limit of refraction allowed. Contact lenses not permitted. Laser therapy, that is for correction of refractive errors, is not acceptable in any condition. So remember, any abnormality of the eye or the visual system, be it congenital, traumatic, or pathological, can be a cause of rejection even though the visual function is well within standard limits. And that decision is up to the examining ophthalmologist. Now, the naval aircrew. Naval aircrew obviously require the best possible vision, so it should be minimum 6 by 6 in the better eye and 6 by 9 improving to 6 by 6 in the worse eye. Color vision, CP1. Again, the fundus should be absolutely healthy. Manifest squint, ptosis interfering with the visual function, chronic uveitis are a cause for rejection. Air traffic controllers. Air traffic controllers, they are allowed to wear glasses up to better eye being vision of 6 by 6 uncorrected, and the worse eye 6 by 9 correctable to 6 by 6. Submarine personnel, visual acuity must conform to the visual standards of S1A1. That is, it should be 6 by 6 in the better eye and 6 by 9 in the worse eye, improving to 6 by 6. And they should be CP1. Now, as far as LASIK or any equivalent refractive errors, refractive surgery is concerned, first and foremost, a certificate must be obtained from the center that LASIK has been done. The age should be minimum 20 years at the time of surgery. Minimum 12 months should have elapsed between the surgery and his coming for examination. The axial length by IOL master, which is the gold standard for us, should be equal to or less than 26 mm. The retina should be healthy, and procedures like radial keratotomy or any similar kind of a refractive surgery makes a candidate permanently unfit. Now coming to the Air Force. Obviously, the visual standards in Air Force, the requirements are far more stringent because they not only require good visual acuity, but they also require good depth perception and contrast sensitivity. Now coming to NDA, either in Kharakpasla or in the Air Force Academy. They allowed refractive error, that is up to 6 by 6. Excuse me, I'll be covering 2, so I need one more time. So the vision requirements are 6 by 6 in the better eye and 6 by 9 in the worse eye, which should be correctable to 6 by 6. Color vision should be CP1. Now coming to the air crew, other than the flying group, their refractive error they allowed is more. They allowed up to 6 by 24 in the better eye, 636 in the other eye, which should be correctable to 6.6 and 6 by 9. CP1 is again the basic requirement. As far as the Adam group is concerned, they are allowed far more refractive error, which should be, however, it should be correctable to 6 by 6. Again, the color vision required is CP2. Finally, the maximum amount of leverage which is given is to the metrological group, in which they are allowed to have a refractive error of hypermetropia up to 3.5 and myopia up to minus 3.5 with astigmatism. Color vision should be CP2. The logistics and the education branch, again, the requirements, the permission is the same as that of the previous category. The dental and the medical people, they are allowed the maximum amount of leverage with a refractive error of up to minus 5.5 being permitted. However, the vision should be, with correction, should be 6 by 6. Color vision should be minimum CP2. Other causes of rejection can be squint, manifest squint, ptosis. Ptosis, which is moderate to severe. Heterocorbia iridis, the candidate is unfit. Sphincter can be considered fit if the difference in the size of the two pupils is less than 1 mm. If the candidate has been operated for cataract in pseudophakic, then he is absolutely unfit. Entropion and ectropion, candidate is unfit. All cases of progressive pterygium, again unfit. Nystagmus, all cases of nystagmus except physiological nystagmus, unfit. Uveitis, especially if there is evidence of any permanent damage, unfit. Corneal scars or media opacities, unfit. Similar with lenticular opacities. Optic nerve drusen, unfit. Now, as far as the corneal scars and the lenticular scars are concerned, opacities are concerned, some amount of leverage can be given to them if they do not involve the visual axis. They're in the far periphery, they're non-vascularized, chances of progression are not there, then you can consider making them fit. Otherwise, they're definitely unfit. CD ratio, a high cup disc ratio, you have to look at him with suspicion, especially if the ratio, there's an asymmetry of more than 0.2 between the two eyes. Of course, if there's a retinal nerve fiber layer involvement or there's a visual field defect, then the candidate is unfit. Night blindness. Now, in Army, Navy, and Air Force, all three services, the candidate at the time of recruitment or commissioning is supposed to give us a certificate that he or his family does not suffer from any congenital night blindness. This is taken across the board. Retinal lesions in the far periphery, non-progressive, he can be considered to be fit. However, if it involves the central fundus, then he's unfit. Similarly for lattice. Keratoconus, of course, any case of keratoconus will be considered unfit. I've gone through Navy and Air Force. As you can make out, the Navy and Air Force criteria is far more stringent than the Army. But then that is for obvious reasons, because the work is far more technical, involves very expensive machines. And in some cases, like in Air Force and all, contrast sensitivity and depth perception also play a very important role. I hope I could actually educate a few of you about what are the requirements at our level. Thank you.
Thank you, sir. Thank you for a very elaborate discussion on visual standards in Navy and Air Force. Next, I would like to invite Dr. Shrishti Khula for her presentation on color vision standards in the armed forces. Over to Shrishti.
Thank you, sir. So color vision deficiency is generally considered unsafe for military special duty occupations, as color is broadly used in navigation, warning, instrument panel, traffic control, and other critical operational tasks. Therefore, it has always been imperative and crucial to follow standardized methodology to detect and screen out such candidates. Color vision deficiency affects 8 to 10% of the male population. Protan affecting long wavelength cones, deutan affecting medium wavelength cones, and tritan affecting short wavelength cones are the major congenital color vision deficiency categories, with deutan and protan defects having greater prevalence. So I'll be covering my topic, presentation in these subheadings. Ishihara test is based on pseudo-isochromatic plates and is used for the screening test during medicals for recruitment, but only for ground duties. It includes demonstration plate, which is visible to all, then the transformation plates, in which color vision deficient would read differently than the normal ones, the vanishing plates, which are visible only to the normal individuals, hidden digital plates, in which are visible only to color vision deficient individuals, and finally diagnostic plates, which help in identifying the type of color vision deficiency, that is protanopia and deuteranopia. So based on this test, we have the following classification or the grades of color perception. Firstly, it is CP2, in which candidate identifies the numbers on all plates from plate number 1 to 17, that is the transformation plates and the vanishing plates, and lastly the diagnostic plates correctly. Then we have CP3, in which the candidate identifies plates which are used for diagnosis, that is 22 to 25, and which are read absolutely correctly. And lastly, we have CP4, in which the individual is unable to read the plates starting from 2 to 9, that is transformation and vanishing plates, as well as the diagnostic plates. So lantern tests were designed as practical means for measuring the ability of seamen, railway personnel, and airline pilots to identify and discriminate navigational aids and signals. These are the various types of lanterns which were used historically. Indian military color vision standards are based on Martin lantern test. So the method that we used for Martin lantern test is, color vision is firstly documented by Ishihara test for all the candidates. Then the candidates are dark adapted for 20 minutes. And the procedure is explained after 20 minutes. And then they are made to read identify the colors by small apertures and are tested at 6 meters in the dark room. If the candidate fails to do so, here's a short video in which we are changing the colors, and you can identify that there are two colors which are being flashed, red and green alternatively, and as well as white color. So the individual has to identify the right colors in the same sequence. If the candidate fails to do that, then the candidate is made to read the same at 1.5 meters distance with large aperture. This is the large aperture video. And based on this, we again grade the individuals on 4 categories. That is CP1, that is color perception 1, in which the candidate identifies without hesitation all colors shown in small aperture of Martin lantern test at 6 meters in a perfectly darkened room, and also passes Ishihara test. Then we say CP2, which is purely based on Ishihara test. CP3, also known as color defective safe, in which candidate who recognizes the red and green signal with large apertures of Martin lantern at 1.5 meters. And fourthly, we have color perception 4, that is color defective unsafe, in which the individual is unable to recognize the signals by Martin lantern with large apertures at 1.5 meters correctly, as well as the candidate fails the Ishihara test. So based on these criteria, we have visual standards for selection as officers in the Indian Army. in which our officers of the Indian Army Aviation, for them we have very stringent criteria, that is we accept nothing but CP1. For the rest, for the officers, for the rest of the army, CP2 is acceptable. Then similarly for recruitment as soldiers in the Indian Army, CP2 standards are acceptable. Similarly, visual standards for selection as officers in the Indian Navy, we have CP1 for those getting commissioned via the NDA or for the aviation, and for those who are applying through CDS exam and via the National Cadet Corps. For the rest, CP2 criteria is acceptable. And for officers and airmen in the Indian Air Force, for the fighter pilots and weapon system operators, as well as the air crew, which are with the fighter pilots, CP1 is the acceptable criteria. For the rest, CP2 is acceptable. And even CP3 can be taken for accounts, logistics, and education branch, which are basically for ground duties. So paper-based, I went through the literature and found out that what are the standards that are followed by the US military. And I found out that they are following paper-based pseudo-isochromatic plates and Farnsworth lantern test for screening tool in the US military since World War II. For gold standard, they are using the Nagel anomaloscope that I've shown here, which uses a specialized color match based on Rayleigh's equation and gives anomaly quotient for diagnosing and classifying the CVD. And after introduction of computerized vision test, US military color vision standards have evolved in recent years to include computerized vision test. So basically, they are using Rabin cone contrast test. This is the photograph of that, of the chart, in which computer-based cone-specific color contrast sensitivity test is used, and it is comparable and maybe better in detecting and classifying the color vision deficiency. Secondly, they are using color assessment and diagnosis test, which measures red and green and yellow-blue color detection thresholds in 16 hue directions, and it is capable of quantifying the severity of color vision loss more reliably than the Nagel's anomaloscope. And thirdly, they have Wagner computerized color vision test, which is a computer-based pseudo-isochromatic plate test that employs the same color confusion principles by employing colors based on isochromatic confusion lines. So we are also in the Indian Army working on systemic analysis of Indian military color vision tests and passing criteria, which are essential for selection. And it is currently under process for replacing the legacy of Martin lantern test without compromising recruiting, accession, and safety. Thank you.
Thank you, Dr. Shrishti. That was excellent coverage of the color vision. Color vision has seen various changes over the years. However, for some reason, we are still stuck in the lantern era. Now, the surprising part, she covered the Martin lantern. People will be surprised to know that the last piece was manufactured in 1939 in, I think, the UK. After that, the manufacturer stopped. So I think the armies and Air Force are the only ones we are holding on to 6 pieces and still carrying out the color vision based on that. 6? Okay. So the problem here is that nobody else uses terminology like CP1, CP2, CP3, CP4. There is no such corresponding usage in the civil for these standards. The origin of these lantern tests actually lies in the railway era and the sea-going people. So the basic idea was to see the lighthouse light, or in the railwaymen, you see the signal colors. So that was the origin of these lantern tests. It actually originated from the UK railways. So basically, the signalman and the loco driver could see through the fog at a certain distance these 3 pure colors. That was the origin of these color tests. This is what we translated into the armed forces. And we are still continuing with that. We have had internal studies also where Ishihara plates have been compared with lantern tests. And we have found out that anybody who's CP2 on Ishihara is also CP1 on Martin lantern. So it's a good case for actually using Ishihara tests which are available and standardized and translated into CP1 because they give the same results. There's nobody who's CP2 and turns out to be non-CP1 on a lantern test. So it's actually infructuous testing them again. And that is the whole idea. Now, we've gone through this entire session. You've seen the various standards that exist in the armed forces. Now, as I covered in the introduction, the requirements are different, the terrain is different, the job profiles are different, and at the end of it all, the exposure to trauma is much more than what you find in the civil. So obviously our intake has to be very strict, and our standards are based on that. And the visual standards are based on the job requirements. So every place that you see the soldier GD, that is the maximum population in the armed forces, or the seamen, or the basic airmen, they require a vision of 6'6", because these are the ground soldiers who are doing your day-to-day tasks. So there no laxity is allowed. We are very strict with that. The whole idea of presenting this IC was that the general public comes to know of it, because in the tier 2 towns and the tier 3 towns, there is a lot of population who is eager to come into the armed forces. And they are not aware of these standards, even though they are available on the UPSC websites. They advertise before the entries. So there are local touts, etc., who take advantage of them and give them various treatments. We have not covered ortho-K. Ortho-K lenses are a big problem in the armed forces, because anybody with a refractive error, he starts using ortho-K 3 months before his entry. His power, anybody with a power of 1.5, and then he comes for the recruitment and you find he's 6'6". And there's no way of detecting that he's been using ortho-K lenses. So unless you suspect such a thing, it is difficult to pick up, and it is people in the civil only who advise them. So that was the whole idea, that this is our requirement. People should not actually tamper with this process, because it is the safety of the individual and the safety of the nation which is ultimately at risk. Another major issue is the refractive surgery. Refractive surgery, in the US, the FDA says after the age of 18, you can undergo refractive surgery, whereas in the armed forces, we have kept a cutoff of 20, because in a very small subset of individuals, we have people with maybe 1% of the population, people undergo a refractive shift, a normal growth shift, even in the age of 19 and 20. So that is why I've said anybody getting refractive surgery done prior to the age of 20 is permanently unfit for life. And that is why it is not allowed at NDA also, which is a 17 to 18 years of entry. So these are the basic ideas. So refractive surgery has a totally different interpretation in the armed forces. Similarly, the axial length in the refractive surgery. So I thank all the speakers. I think they've covered all the topics. And I thank the audience for a very patient hearing. I hope this has transmitted some of our concerns to you, and this gets transmitted into the population. When you see people eager to join the forces, you guide them accordingly and in the right way. Thank you so much.